All right. Welcome, everyone. We were just getting set up front. Thanks, everybody, for coming. I see some familiar smiling faces, some faces I don't know, but we certainly appreciate all of you showing up today and being here. We have a number of people on our panel to talk to you a little bit about a disease which I suspect most of you know much more about than we do, probably through personal experiences. This is kind of an interactive session. Certainly, if you have questions or comments, we try to entertain all those. I also do this for our lung cancer group, so I just want to remind everybody that, a lot of these things are very personal and confidential and kind of things we talk about here. If anybody brings up anything personal, just respect them. I want to introduce the speakers for today. Jim Metz, many of you know, he's a radiation oncologist. One of my favorite medical oncologists, or sign a title mom. Antonia Spallata, who's our pathologist. Vinay, who's one of our new GI doctors. Many of you have been through upper endoscopies and endoscopic ultrasounds and those things. And Dr. Dan Dempsey, who's one of my colleagues and a co-surgeon. Actually, he was chief at Temple for many years and is now the chief of the GI division at Penn. And so everybody will be talking to you. Dr. Metz, our radiation oncologist, is going to go first and talk a little bit about esophageal cancer and radiation therapy and some of the new and exciting things that are going on at Penn. He's going first because he's got a busy schedule. He's going then to the pancreas section. So Jim will be the first speaker.
Great. Thanks, John. Thanks, everyone, for coming out today. I see a lot of familiar faces out there also. And I'm just going first because I'm doing these other sessions, but and I'll be back and forth to answer questions and things like that later. And this is what I'm going to talk about is really new developments in radiation oncology, where we're going. But I think most importantly, I think many of you recognize that have gone through this, dealing with esophageal cancer and gastric cancer is what we call a multimodality approach. And that's why all of us are here today. It's really a combination of surgery, radiation, medical oncology, GI, nutrition, all kinds of various services we try to pull together to help people through this. So I'm going to talk a little bit about my approach to this and where we're going. One of the things I want to emphasize, we hear more and more that in cancer treatment in general, the word we hear about now is targeting. And how are we doing personalized therapies or targeting for patients? And I'm going to talk a little bit about what I do is physical targeting using radiation. Surgery does physical targeting using surgery. But more and more we're hearing about biologic agents or agents that are developed to deal with specific abnormalities. I think Orsino will mention some today, talking about dealing with the molecular biology. And in the end, what we try to do is bring these together, molecular biology and personalized medicine with targeting going forward. Now, the radiation oncology has undergone many different developments over the years, and it's really been about two things. It's been about the developments of imaging, and we've moved from regular 2D, regular X-rays through CAT scans to MRIs to PET scanning, but also the development of computers. You think about the changes that have happened over the past 30 years because of computers in almost every modality. Radiation is very much tied to those two things. And if we even look back at the 1960s, the first linear accelerator treated patients, this is a picture of a kid sitting on a table where they set him down and they said, don't move, and they ran out of the room. So, and many of you have been treated. It's very different now from what it was only about 40 years ago. So dramatic changes which have happened. And we've really moved towards doing functional imaging or PET scans to really help guide us and be very precise in where we want to deliver the radiation treatments. But I want to talk about a few things. One, where are we now? Also, the multimodality care plan model and, where we're going with things in general. Where are we now? First of all, I think we've come a long way, but we also have a long way to go. We're getting more and more focused not only on people doing well and getting rid of the cancer, but how they live after the cancer long term and trying to minimize any toxicities that we really bring to the table. And all of us you'll hear about today are looking at new ways to do that and new ways to entertain that. I think at Penn we've been on the cutting edge of that, but we all recognize here that there are improvements to come down the road. And that's why we work together as a team. You know, when we look at patients with esophageal cancer and gastric cancer, we actually have a meeting once a week with all of us together in one room and figure out what's the best for that individual patient. So we all understand that more minds are better than one, and try to put this with a multimodality approach. When we do that, we also need to be very careful to think about how do we approach this without burning any bridges for the future. Because any one of us can work in a vacuum and make it difficult for the other one to do their part in this. And we're very careful about that when we do our planning. We've also learned that we need to do a lot of supportive care to help people through this disease. And that may be nutrition, that may be putting special nutritional things like as feeding tubes in place temporarily to help people. That may be psychosocial support to help them through. That may be counseling services. And we try to pull all those in when we think about patients when they start treatment from the beginning. More and more, we're adding in advanced imaging. You know, our new center at Penn, at the Proton Center, has lots of advanced imaging, and we're building more and more into this to help drive where we're going in the future. With all, in the end, we want to get to improve outcomes. And again, I want to come back to, when we want to improve outcomes, it's not just survival outcomes. It's how people live with this afterwards and live with what we've done to get them through this. Well, where are we going? There are some exciting times coming ahead. And what I try to tell people at this conference is, I think many of you are interested, where's the field going? Where are we going beyond what many of you experienced already? So I'm going to talk a little bit about that, specifically on the radiation realm of things, where I see the future coming along. How do we really identify what we want to treat? Which that may sound simple. It's actually not that easy all the time in identifying things through imaging going forward. So one of the things I'm going to concentrate talking a little bit is about proton therapy, because that's one of the realms I see being integrated into the care of esophageal and gastric cancer patients down the road. We're just beginning to do that. So really, what is that? So we consider using proton therapy for a number of reasons. One, you know, when I think about how protons work, they actually work the same as regular X-rays. So from a biology standpoint and effectiveness standpoint, it's actually very similar if we use the same doses between the two. However, the benefits of using proton therapy is we can actually reduce the amount of normal tissue that sees radiation significantly. And that opens a lot of opportunities for us. One, we think it's going to decrease some of the side effects people have from radiation. And it allows us to treat tumors such as the esophagus and the stomach that are very close to a lot of important tissues that we have some challenges sometimes treating because it may be right near the spinal cord or right near the liver or right near the kidneys. There's some real challenges with giving too much radiation there. We can potentially give more radiation, but I think most importantly, it allows us to do some things in combination with chemotherapy, biologic agents, surgery that were just too toxic before. And we've made some decisions in the past not to do certain things because we knew it was going to be toxic. But now with protons, when you're not treating all these normal tissues with radiation, it may open some potential avenues down the road. So I'm a radiation oncologist. I'll show one physics slide. But just to explain it, I'm not going to get into the details, but what this really tells me, when I use a regular radiation beam, so an X-ray, so if you get an X-ray for see if you have a broken bone, the radiation goes in one side of the body and out the other side of the body and hits that X-ray film on the other side. So it gives radiation to everything in between. A proton beam is different. It goes in the body at a much lower dose. It releases all its energy at a point where we prescribe it, and then it stops. So there's absolutely no radiation at all behind the tumor and much less radiation in front of the tumor. And that's why I said earlier, it really reduces the exposure of normal tissues to radiation. This is a complicated treatment. I'm going to show you some pictures, and this is actually from the University of Pennsylvania, what it looks like. So we opened our Proton Center now a little over 2 years ago. And we're just starting to integrate this therapy into some esophageal and gastric cancer patients, but it's very early right now. This is actually the control room. It looks like air traffic control at the airport. I think we do a better job, but basically there's a ton of screens. We have multiple different rooms. We have actually 5 rooms that we're utilizing at Penn for treatment. It's the largest proton therapy center in the world. We just opened our 5th room. for treatment. So we have somebody that actually controls where the beam goes throughout the center itself. This is what's called a cyclotron. This is the heart of the facility. So when we use protons, we actually have to accelerate them to very, very high energies, to 2/3 the speed of light, 230 million electron volts. And we actually have to inject protons in the middle of this, and then these are two big magnets, and they're usually closed. And as it gets more and more radius, it gets further and further out, it gets the highest energy and spits out down the beam line where we want it to go. And this is actually a picture of what one of the rooms looks like. So a patient actually lays on this table. We have different devices they would be on. This is where the beam comes out. And this actually rotates 360 degrees around a patient. Now, what's amazing about this is the second floor of the facility. So these are enormous facilities. You all remember, those that have had radiation before, you walk in a room, you lay on the table, and the gantry spins around you. It's in the single floor. This machine is actually 3 stories tall. And a person goes in on the second floor of this and is in the middle of this machine, and it's rotating around them. And it's about 100 tons, and it rotates to about 1/10 of a millimeter in accuracy. So it's a pretty amazing structure. But why are we doing this? And this gives you an idea. So this is looking specifically at patients that have these GE junction or esophageal gastric tumors that are right at the border of the esophagus and the stomach. And we did some planning studies looking at, can we reduce the amounts of radiation that people receive using protons? And the most important thing is here. When we look at the reduction of radiation to the spinal cord, to the liver, to the kidneys, it's really 50 to 80% reduction in dose to various normal tissues. And that's where we see this potential avenue of opportunities going forward. But again, I want to come back to this. We're doing a lot of really cool stuff at the Abramson Cancer Center with targeting things and radiation and proton therapy. It's not for everybody. It's for certain circumstances, and we have a team here that can really decide what's the best treatment for people. But most importantly, I think what we have going on at Penn is we really understand how we bring all these together with surgery, with chemotherapy, with biologic agents to come up with the best plan, and not one functions by itself. It really is this combined approach, and I hope as we talk today, you really understand that and how we put this all together as each of our speakers go forward. So I think we need to continue to optimize things. I think we have a long ways to go. Our goal is, we always know we can improve. I think if you get to a point that you say, we've got the best we can be, then you stop. I think we realize we always need to go further. That's our goal at the Abramson Cancer Center. Can we keep improving therapy? And that's really what we want to get down the road. So thank you very much for your time.
Are there 1 or 2 quick questions? Otherwise, Jim's going to leave, but he will come back if anybody has any particular questions about the Proton Center or anything like that.
So the Proton Center now is actually treating a wide variety of cancers. We started treating with some prostate cancers that get experience. We're now treating lung tumors. We're now treating esophagus, gastric, pancreatic tumors. We actually have an entire protocol for treatment of tumors that have recurred in an area that got radiation before. One of the mantras out there is, once you get radiation, you can't get radiation again. The reason that is, or people say that, is because the normal tissues can't see more radiation. But now that we can come in a different way and we can miss those normal tissues, we actually have an opportunity to treat people if they have a recurrence of cancer. And that's actually one of the most rapidly accruing protocols, and has given us new opportunities at Penn to treat people when we have other options before. So the nice thing is now we've built a center that actually can treat all conditions, from pediatric all the way through all the adult conditions.
And just to point out that one of the reasons we're so excited about the esophagus and the proximal gastric cancers for protons is those structures are in very high districts of your body, and those are areas where we really want to spare the tissues collateral damage as much as possible. And what are they? They're things that are really important, like your heart, your airway, your lungs, and your spine. So all the things that are originating in the midline. And I think it's given our patients a real advantage. And the other thing Jim didn't mention, but probably should, is that every patient that goes through proton facility treatment is studied and on a research protocol. So not only do we hope that it helps you personally, but we also hope that the endeavor and the experience at Penn generates new knowledge, and that moves us all forward. So I don't know if you want to comment on that, how people get on the proton.
Yeah, I think that's really important. We have made the conclusion that the data for proton therapy, although it's expanding rapidly across the U.S. and the world, is not out there solid yet. And we are actually treating everyone in clinical trial. I think it's very important that we understand the best way to do this and how we help people down the road, because we have to look to the future. So we've certainly appreciated those patients that have gone on these trials. And your doctors at Penn are all aware of these trials that are there. So if there was ever a need, we're certainly willing to see people and talk about that. Okay. Yeah, we're not doing randomized studies in comparison. We make a determination what's the best treatment for that individual patient. But what we're doing is tracking people prospectively, how they do, and comparing the side effects, comparing other things between the two. So we're very careful in how we select the patients, but right now it's not randomized between one or the other.
Well, we do have a pretty large historical population.
Yes.
Like a more traditional primodality therapy.
So I'll be back a little later, too.
Great.
Thank you very much.
So next, we're going to hear from Vinay. He's a gastroenterologist, and you'll notice Dr. Coachman, who was the host of the session before this, our gastroenterology colleagues are very involved, and it's a great group to work with. He's going to talk to you a little bit about the role of endoscopy and esophageal cancers, talk a little bit about diagnosis, and are you going to touch a little bit on treatment of early Barrett's and stuff? Yeah, and one of the things that's changed for me as a thoracic surgeon, some of you know who have started out with Barrett's, we oftentimes would take out your entire esophagus for early Barrett's, and we really haven't done that anymore. We've turned a lot of that over to our GI colleagues who have some pretty impressive ways of treating it, and in some cases eradicating it and avoiding surgery, which would be a great thing for everyone, actually. Even me. You might not realize that.
Hi, everyone. Thanks for coming. I hope you've had a good day so far. My name is Vinay Chandrasekhar. As Dr. Kaharchek mentioned, I'm a gastroenterologist. And so what I want to talk about today is, the role of endoscopy from diagnosis to treatment, and to talk about some of the new technologies we're using to help treat patients with early cancers and precancerous lesions. So just to review, the esophagus, the hollow muscular tube, it's about 10 inches or longer in length, and it empties into the stomach. So most of the tumors that we see actually are from acid reflux, where they originate from what we call the GE junction that Dr. Metz talked about before, the esophagogastric junction, or are within the stomach. And these can range anywhere from the pylorus all the way to the body of the stomach or to the antrum. So esophageal cancer, when people say esophageal cancer, what are they talking about? Well, there are various types of cancers, but there are two main types that people are talking about. That's adenocarcinoma and squamous cell carcinoma. And what we're seeing more and more with chronic acid exposure with acid reflux is adenocarcinoma, which arises from the glandular cells, most commonly in the lower esophagus. Now, squamous cell carcinoma is something that we've historically seen, and that arises usually in the upper and mid esophagus, and both have strong risk factors, and overall, it affects people who are male, over the age of 50 is the highest risk category, with chronic acid reflux. Usually we used to say 15 to 20 years of acid reflux, but now we're seeing patients who give a shorter duration, say they've only had acid reflux for 5-10 years, and we're starting to see these early cancers. Barrett's esophagus, which we'll talk about, which is a change in the lining of the esophagus in the lower portion of the esophagus in particular. Tobacco and alcohol definitely have effects on the development of squamous and adenocarcinoma. And diet, and we'll talk a little bit about that as well. So in terms of gastric cancer is something that in the U.S. as a whole we see a little bit lower than in other countries such as Asia, Japan, but we have lots of different cases. So when someone says they have gastric cancer, they could be referring to one of a number of different types of cancers. The one that people think of classically when they say I have gastric cancer, that's adenocarcinoma, again arising from the glandular cells. But this can encompass different types of cancers such as lymphomas, which arise from the immune system, carcinoid tumors, which arise from the hormone-producing cells, and GIST, gastrointestinal stromal tumors, which arise from the nervous connections. But for today's purpose, when we say gastric cancer, and for the rest of this talk, we're really talking about adenocarcinoma. So the risk factors, we talked, I mentioned that diet plays a role. Well, diets that are high in salt, pickled vegetables, smoked foods, and people who have a diet that's low in fruits and vegetables are at higher risk for developing cancers. And that's particular for gastric cancer and some esophageal cancers as well. Family history definitely plays a role, as does chronic Helicobacter pylori infection in the stomach. Now, Helicobacter pylori is a bacteria that colonizes the stomach in half the world's population. So it's the minority that will develop cancer as a result of this, but this is a known risk factor for gastric cancer. Smoking and gastric polyps, which are polyps just like in the colon. Most gastric polyps are actually benign, but there are certain gastric polyps that have precancerous potential. And so it's important for us to identify those polyps and to remove them at that time. So what is the role of endoscopy? Well, as many of you know, when you first have a concern of a potential for esophageal or gastric tumor, you go to a gastroenterologist for an endoscopy to see what's going on, what's in the stomach, what's in the esophagus. And then we have different techniques for staging the tumor, for treatment of early and superficial tumors, which is a very exciting field at this time for gastroenterologists, is that the treatment of early cancers and precancerous lesions so that people will never develop a cancer down the road. Surveillance for people who have had cancers in the past and to check for recurrence or for precancerous lesions. And for palliation of symptoms for people who have very aggressive tumors. Now, what are the different techniques that we have? Well, upper endoscopy is the standard that we've used. And although some of the techniques with traditional standard endoscopy are the same, our imaging technologies have improved such that we now use high-definition instruments. So just like your high-definition TV at home, we use high definition to look at the esophageal lining in the stomach. So we're able to see lesions, very tiny, subtle lesions that we weren't able to pick up earlier. And so we have the patient lying on the left side. We have a long, flexible tube that we insert after they're asleep in the mouth, down into the stomach, into the upper portion of the small intestine. And so we're able to carefully visualize the stomach and the esophageal lining. We have instruments that allow us to take biopsies, to do other techniques in terms of removing big polyps, in terms of switching the lens to look with a filter called narrowband imaging to see if a subtle little dimple is truly a polyp or if it's just a fold of tissue. So when is EGD recommended specifically for looking for cancer? So what are the sort of the symptoms that we think about? Well, it's a combination of risk factors and symptoms. So going back to the risk factors, if someone tells me they have had acid reflux for 20 plus years and they have this indigestion that won't go away, well, that's an indication for an upper endoscopy. New symptoms for someone particularly over the age of 50 is definitely an indication for an endoscopy. Symptoms of GI bleeding, anemia, unintentional weight loss, and an abnormal prior study. So if someone gets a CAT scan for a lung nodule and then they see some thickening in the esophagus, that'll prompt us to take a look with an upper endoscopy. Now, endoscopy allows us to help diagnose what's going on, but it doesn't give us the full picture because it's a camera within the stomach or the esophagus, so it can only look at the superficial lining of the esophagus and the stomach. But it can give us some good information regarding the size, the shape, the appearance of the lesion. It can also allow us to perform biopsies. Is this a cancer? Is this a precancerous lesion? Is this an adenocarcinoma or a squamous cell carcinoma? So what we typically see, and I try to use cartoons as much as possible just so it's easier for everyone to see and understand. But when we look, it very much looks like this. There's a lesion, we go down, the lining looks normal above it, looks normal below it, and then all of a sudden we run into a mass or an ulceration, and that's the area that we're able to detect and selectively biopsy. In the stomach, when we see an adenocarcinoma, we can see ulcerations, and so for those of you who are interested in what we see in real time, this is what it looks like with a tumor. It looks like a little ulcer. And so sometimes it's very difficult to tell what's an ulcer and what's actually a tumor, but we biopsy these lesions and we turn to our pathologist to help us and say, are there cancerous cells in that ulcer? Now, endoscopic ultrasound is a modality that we use to help with staging. And so after someone's been diagnosed with a tumor of the esophagus or the stomach, we typically, the next step is to do a CT scan to make sure that there's no widespread of the tumor. And if the CT scan looks good, the next thing that's recommended is actually an endoscopic ultrasound. And what this is very much like an endoscopy, but at the tip of the scope, we have an ultrasound probe that allows us to look at the wall layers and to look at the surrounding structures around the esophagus and the stomach. So it allows us to look at beyond the walls of the superficial layer. And so we have two different ways of doing this. One is a scope that looks 360 degrees around, and then the second scope looks 90 degrees, but allows us to biopsy, particularly for lesions that look like they're outside of the superficial lining, or for lymph nodes. So this provides us with very good way of staging these tumors. And when I say staging, there's several components. One is obvious distant spread, but we also want to know how superficial or how deep is the tumor within the wall of the lining of the esophagus and the stomach. It'll also tell us what lymph nodes are involved. Is there an abnormal looking lymph node that looks like it may be involved? Are there no lymph nodes involved? And that allows the team to come together and say, well, this is the best treatment option for this patient because there is no spread or because this lymph node's involved. Now, endoscopic ultrasounds, as I mentioned, used in conjunction with CT scan and MRI. And some of the benefits is that there's no radiation exposure. It's an ultrasound. It's suitable for patients who have allergies to IV contrast or who may have implanted metal in their body, so it's difficult for them to get an MRI. And it's often used in conjunction with a latex balloon, which allows us to see the wall of the stomach much clearer. The balloon provides acoustic coupling to allow us to see the different individual layers of the wall of the stomach and the esophagus. So to give you an idea of what I'm talking about, this is a cross-section of the stomach. So there's the mucosa, which is the superficial lining, the submucosa, the muscle layer, the muscularis propria, and then in the stomach there's the serosa and there's the adventitia in the esophagus. These are the different wall layers. So when we're trying to stage a tumor, we're trying to decide, is it very superficial? Is it in the submucosa, which is deeper? Does it go into the muscle layer, or does it go into surrounding structures? Now, it also, as I mentioned, allows us to look at the lymph nodes. And so with the lymph nodes, we can see what looks like a benign appearing lymph node versus a malignant lymph node. And the way we do that is using several different echo features. So one is the size. If it's less than 1 centimeter, it's most likely benign, but not always. If it's hyperechoic or bright, that's a reflection of a benign lymph node. If it's dark and punched out, that's more suggestive of a cancerous lymph node. And then if it's something that's in question, we'll be able to put a needle directly into that small lymph node, 6 millimeters, 8 millimeters, and obtain tissue from that lymph node to look under the microscope and see if there's any cancerous cells. Now, probably the most exciting development in our field are the treatment options that we can now offer. Before, we would send everyone to surgery, But now we have different techniques that can help us with maybe potentially curing early cancers or treating precancerous lesions before they have a chance of becoming cancers. And so right now, endoscopic treatment is really limited to those tumors that are confined to the superficial wall of the stomach or the esophagus. And so that when I say superficial, I'm talking about the mucosa or the submucosa. Now, the main technique we use at Penn is called endoscopic mucosal resection. And what that is a technique where we have different ways of doing this, but if this is the superficial lesion, say it's in the stomach, we inject saline or some filler into the lining of the wall of the stomach, lift up this lesion, and then we use a hot snare to remove the lesion. Ideally, we like to remove the lesion in one piece, but in some instances, if the lesion is too big, we'll have to take multiple pieces. The other technique that and so this is a picture of a small subtle thing that came back as a cancer. We lift it up with that blue saline, and then you take it off with the snare, and it leaves a little divot, and the body heals this up on its own. It's completely cured that early cancer. Now, the other things that we have, and this is another technique that we use particularly in the esophagus, where we put a rubber band around the lesion. So we suction the lesion into our cap, into the channel, and we deploy a rubber band around it. And then the tissue is entrapped in this rubber band, and then we use a snare to cut the piece off. And so this, again, is another subtle lesion that this is our banding device, and it's kind of hard to see, but this is the lesion here, and there's a rubber band around it. And then we put a snare and cut it off, and there's the piece that's fallen off right next to it. And so we're able to remove pieces of tissue. And this technique is good for not only treatment, but it gives us a very good histologic assessment. So we can tell us accurately, is there any invasion into the submucosa, or is this completely confined? And then my pathologist will say, hey, you know, either you got this all out, or it extends to the margins, or it looks like it's invading deeper, and then we know what the next step is. So a few more things that we can offer. And so for patients who have very aggressive and advanced tumors that are nearly totally circumferential, and they're having difficulty swallowing or having nausea and vomiting, one of the options we can offer are metal stents. And these are stents that help open up the lining of the esophagus and the stomach, so that patients can eat and get and drink liquid and get hydrated and not have to keep coming into the hospital for IV fluids. So what we do in this situation is, if we have a tumor that's near circumferential, we're able to put a metal stent, which is like a straw, and keeps that lumen, the diameter patent, so that things will go through and won't get stuck, and they won't have problems with coughing or regurgitating, and they can stay hydrated. Now, this is in the esophagus, which is probably the most common indication that we use this for, but we can also place these in the stomach for tumors right here at the junction with the small intestine. We can put a stent here, and this is a small picture that I've included showing what a stent looks like during an endoscope. So lastly, I'll talk about treatment of precancerous lesions, and this really speaks to esophageal adenocarcinoma with Barrett's esophagus. And so what we see here is that there is a change in the lining of the esophagus in people who have had chronic acid reflux. You can see this kind of red change compared to the normal white mucosa. And this is a change in the lining of the cells from squamous cells to columnar cells as a result of chronic acid reflux. And this does have precancerous potential. Now, there's a finite, there's a way that it progresses. So it progresses from Barrett's esophagus to low-grade dysplasia to high-grade dysplasia to adenocarcinoma. So just because someone has Barrett's esophagus, their risk of developing cancer can be anywhere from 0.1% to 0.5%. So we don't treat everyone with Barrett's esophagus, but we monitor them, we survey them. So if they have evidence of high-grade dysplasia, which is one step removed from cancer, then we have eradication therapies, including mucosal resection, which I showed you, or a newer technology, radiofrequency ablation, which basically uses a catheter, either a circumferential 360-degree catheter or a 90-degree catheter, that where we can deliver radio waves directly to that tissue to burn that superficial lining off. And what this does is, in the majority of patients, in one study it was up to 98%, after 2 to 3 sessions, you can cure the patient of their Barrett's. Now, those numbers may be a little bit higher, but it's the overwhelming majority that do respond to these therapies. So I hope I've given you some insight about what we do as gastroenterologists, the future of endoscopy and the promise that we have for detecting early lesions and potentially curing them with endoscopy, and the different tools and techniques that we have to go about this. And so this is the Proton Center where I spend most of my time. Thank you.
Thanks. Does anybody have any specific questions? Yes.
When it comes to GERD, what exactly causes GERD? Why do people get that?
That's an excellent question. That can be an hour-long talk alone. But you know, for acid reflux, there's a lot of different factors involved. So abdominal distension, certain foods in diet, caffeine, alcohol, lowers the lower esophageal sphincter pressure. So there's a muscle that's right at the esophagus and the stomach junction where it relaxes, and if it relaxes more frequently, people can get acid reflux. So that's why diet's very important. Obesity, where people have a lot of weight on their belly, causes pressure on the stomach, causes acid reflux. Laying flat, we all reflux 4% of the time. That's normal. But when you lay flat after a heavy meal, that causes acid reflux. So there's many different factors that cause acid reflux, and so it's looking for one particular or 2 particular items for each potential person. You have to go after those sorts of things. And some people, it's just the way their body is. That's how they are. And Dr. Dempsey has some additional comments.
I want to ask you a question because I think it would be. So could you tell us if your brother or father were diagnosed with Barrett's esophagus by a good endoscopist and a good pathologist, Barrett's esophagus, no dysplasia, what would you tell them? What would you tell them their lifetime risk of esophageal cancer is? Would you tell them they had to stay on a PPI for the rest of their life? Would you tell them to have an anti-reflux operation? What would you tell them?
Well, that's a good question. Well, there's a big debate within GI right now with Barrett's esophagus and no dysplasia. So several factors come into play. One is the length of the Barrett's. So if it's a short segment versus a long segment, so if it's a segment that's occupying 10 centimeters or so, that person has a higher risk because there's more tissue that's involved. Now, what I would tell the person is that there's a 0.1 to 0.5% chance of developing cancer each year. And so the first thing I would do is I would repeat endoscopy on a surveillance plan every 2-3 years if it's short segment or less than 5 centimeters. If it's a young patient who has 40, 50 years of their life ahead of them, that's when you think maybe surgery may be the best option because they're going to be coming in every 2-3 years for the rest of their life. Now, in terms of acid reflux, there's a debate as to whether PPIs alone, acid medications, can halt the progression of Barrett's from low-grade dysplasia to high-grade dysplasia and developing cancer. But for symptoms, I definitely would recommend that someone is on a PPI. So there's different factors: patient age, the length of the Barrett's. In terms of radiofrequency ablation, that's a debate right now. A lot of gastroenterologists are starting to treat these lesions, and we're not sure if that's the right thing to do quite yet. But that's why we reserve endoscopic treatment for high-grade dysplasia right now. Yeah, so that's a good question. The risk of PPIs and chronic use is the main question. So people who are on chronic PPIs are at risk for thinning of their bones, osteopenia, osteoporosis. They're at risk for infections, pneumonias, C. difficile. And so there is a risk benefit to having people on PPI. So what we tell people is we want to have you on the lowest dose of PPI. If you can, we always try to taper off the PPI. For people with Barrett's, you know, our practice is to keep them on a low dose, the lowest dose possible. Proton pump inhibitors such as Nexium, you know, omeprazole, the advertisements that you see for acid medications. So, yeah. I'll turn that to Dr. Kaharcha.
You really shouldn't. So, I would qualify that statement. So the esophagectomies we perform for malignancies, the answers should be no. Your stomach really doesn't make much acid. You've been vagotomized. The vagus nerves are the nerves that really set in motion the production of acid in the stomach. That being said, we do have a small cohort of patients who have some difficulties postoperatively, and we restart them on their PPI, and they feel better. So we're more treating symptoms than we are anything else, and I quite frankly don't understand it. Everyone's stomach does have some basal acid production, but it's very low, and especially in a stomach that no longer has the neural input to make acid. Yes?
Yeah, no, it's individualized. So if it's a younger patient, we definitely try to treat their acid reflux first. We don't just do an endoscope on everyone. So I generally do a trial of 2 to 3 months and see how they respond. And if someone is not responding after 2 to 3 months, or their symptoms are getting worse in that period, we'll do an endoscopy. Now this is taking someone who has no additional known risk factors.
Yeah, we don't screen, for esophageal or gastric cancers in this country, although in some Asian countries they do, and those are societal decisions. They have to do with the number of patients that have it and how much society wants to invest. Obviously, when it's me or it's you or it's someone sitting next to you, we think our life is worth everything. But as a group, certain decisions are made. So, I don't know. When I send you a patient with symptoms, I'm kind of encouraging you to scope them because I kind of want to know.
Yeah,
so,
if we get a referral from you,
right.
That's for an endoscopy.
All right, one more question, and we'll move on, and we'll have time for questions at the end also.
So one of the known issues after esophagectomy is that patients can often have a vagotomy where they have delayed gastric emptying. And so unfortunately our choices of medications for delayed gastric emptying or gastroparesis are limited. But yes, if someone has gastroparesis or delayed emptying after an esophagectomy, we will do a trial of Reglan, metoclopramide, low doses. There are people who do prescribe domperidone, which is available through pharmacies in Canada. We do IV erythromycin if someone's in the hospital. But short of that, our options are very limited in the treatment of motility disorders.
So that's a good question. So there's a couple things that play into it. First of all, you can either have slow motility, stuff's not moving forward and emptying, or too rapid, and every time you eat, you get diarrhea. So there's both spectrums of that problem. And people that I've operated on know that when I first meet you, the one thing I tell you is that God has endowed you with the best system for living, eating, and all those things, and I can't recreate it. We're going to try, but your life is going to be different. And my goal is to give you an acceptable quality of life. It's not the quality of life you had before. And my secondary goal is to allow you to nourish yourself. And hopefully without supplements, without tubes and those types of things. So the reality is that the operations that we have in 2012 are imperfect. They allow you to continue on, but they don't allow you to do it with the same quality of life. It's interesting. I thought a lot. I'm thinking a lot about Paul and the thorn in the side. That kind of resonated with me. And I think that's true. And I think, but, you know, things are improving, and he didn't have time to talk. There's some kind of fascinating things. The GI group at Penn is very, very active and involved. They're very involved in NOTES, which is natural orifice surgery. And, you know, that is the future, you know. Deploy a little robot, he does your esophagectomy from inside, and then I, you know, snap my fingers and retrieve them. And so there's all kinds of kind of futuristic thoughts and ideas out there. And one of Anae's colleagues, Dr. Coachman, actually took a 6-month sabbatical and was over in Europe and basically spent 6 months thinking about and playing with and trying to visualize some things about kind of new ways of doing things, and that's one of them. And that's one of the advantages that our group has, is the institution that we work for affords us that opportunity. So it's great. So we're going to move on. Antonis Spavata is our pathologist. We recruited. I don't know if they're clapping for you or her. She was recruited from Pittsburgh. I don't know how many years ago now. 3 years, 5 years, aging quickly, and has been a very nice addition to our pathology. Has a special interest in esophageal and proximal gastric cancers, it's interesting. Very few people realize what the pathologists do, but they're maybe one of the most important people in your overall future and treatment plan when you're first kind of diagnosed, because they give us the answer and they tell us the extent, and the information they provide is really what we use to map out your treatment plan. Yet you never see them, you never meet them, you never know them. Every once in a while you get a bill from them, I guess, but all right.
Thank you. Good morning, everyone. Very nice introduction. That was pretty much my first sentence that I was going to say. What do pathologists do, and how do we help patients who have these diseases? Okay. So you've already heard a bit of the background, and there'll be a little bit of overlapping information. I'll try to skip when there's too much overlapping information. But there are many types of tumors in the stomach as well as in the esophagus. In yellow are the most common tumors, and those are carcinomas, both in the stomach and in the esophagus. By far, adenocarcinoma is the most common type of tumor in either one of these organs. Now, in esophageal carcinoma, not so much in the United States, but in the East countries, squamous carcinoma is also a frequent disease. We do see some cases in the U.S., however. There is then a host of other types of tumors that are relatively rare, but we in pathology see all sorts of things, and especially being at Penn. You see I used to say at Penn, the rare is common. So anyway, these were already mentioned. I'm not going to go through that. Today, we will primarily focus on the pathology aspects of adenocarcinomas, because those are the most frequent diseases. Again, this was relatively well described, very well, I should say, described already in terms of the locations of these tumors. And we have from the esophageal tumors, with squamous being more proximal, and the adenocarcinomas being more distal, closer to the stomach, and the gastroesophageal junction here, and then all the stomach tumors located either in the fundus body or more distally in the antrum and pylorus of the stomach. So starting with the stomach cancer, and I've had a long time interest actually in studying the underlying mechanisms of stomach cancer, behavior of stomach cancer, molecular characterization of stomach cancer, which is becoming very important nowadays with the targeted therapies that are being developed. But in general, gastric cancer in the United States is relatively uncommon as compared to its relevance worldwide, where it's actually the 4th most common cancer in the world. But as I said, it's overall 14th in the United States, with about 22,000 cases every year. Stomach cancer is generally diagnosed in later in life. It affects more frequently men than women. There are a number of well-known conditions that are associated with an increased risk. And this is important for several reasons. It allows one to prevent, so much like in Barrett's esophagus intestinal metaplasia progression, one has the opportunity to identify early lesions and prevent cancer. But in general, in fact, around the world, Helicobacter pylori infection causing chronic gastritis is the most common risk factor. And in fact, in the world, 70% of the cancers can be attributed to gastric cancer as a major risk factor, not alone. It has to interact with other risk factors. Other conditions such as autoimmune gastritis, which may cause pernicious anemia, also increases slightly but somewhat the risk of gastric carcinoma. Also, previous stomach surgery after many years may increase the risk of gastric carcinoma occurring in the remnant stomach. And a rare type of stomach cancer, but that is very different from the most common forms, is the familial gastric carcinoma. These are tumors that are diagnosed and present very early in life and have an inherited predisposition, can be detected, the risk of those tumors can be detected by actually doing mutational analysis from blood DNA. So what is it that pathologists do? So we actually work at the interface of the interdisciplinary team, providing information at different levels, both from looking at tissue at the biopsy level or at the resection level, or further characterizing specific molecular patterns in the tissue, in the cells, in the tissue that may allow for better treatments, more efficacious treatments of the patients. So diagnosis, when we have resections, then we can help the surgeons, the radiologists, oncologists by providing more accurate tumor staging, which helps in determining the best treatment. We also obviously play a significant role in contributing to identifying the early lesions during surveillance. And these include, for Helicobacter gastritis, and the lesions that follow after these, which I'll show you in a couple of slides down the road. For Barrett's esophagus, the presence of reflux esophagitis and the precursor lesions, intestinal metaplasia and dysplasia. So the pathologist basically receives portions of tissue, small biopsies, very tiny, teeny, like a grain of rice piece of tissue that we process in the laboratory, obtain very thin sections that we put under the microscope after staining with a number of dyes, and that allows us to identify the cells that are important to make the diagnosis. So adenocarcinomas, in fact, both of the stomach as well as in the esophagus, based on their appearance under the microscope, we can grade them as being relatively well to moderately differentiated when we see nice glands, these little round structures, or when they are uniform sheets of cells, then they're called poorly differentiated in terms of their grade. One unique type of carcinoma is the so-called signet ring cell carcinoma, and these are seen most frequently in the stomach, but on occasion also in the esophagus. And importantly, these are the types of tumors that are seen in the hereditary gastric cancer patients. They can, of course, and more often, in fact, are seen in patients who do not have a family history, and therefore these are sporadic type carcinomas. So these are the types of cells that we look under the microscope and we say, okay, signet ring carcinoma. So a little bit about familial gastric carcinoma. These are typically, as I said, signet ring cell type carcinomas or diffuse type carcinomas. These are associated with germline mutations in a gene, the E-cadherin gene. So we can detect these by doing sequence analysis on DNA that's obtained from patients and family relatives from their blood DNA. If a mutation is identified, then the individual at that point might not be a patient that might not have the disease actually yet, be a carrier. And those carriers of mutation, 3 out of every 4 carriers may develop the disease. So because of that, it is important to have genetic testing on those families and consideration for prophylactic or preventive gastrectomy should be discussed. Some elect to pursue that, some do not. There's still some controversy in that area. So now talking a little bit about Helicobacter pylori as a risk factor for gastric cancer. So about 50% of the world population is infected. In the United States, however, less than a third, and actually the frequency is declining over the years, has greatly declined during the last century, which is good. But it is still very frequent in a number of countries like Asia. And even within the United States, with the various ethnic backgrounds that we have here, it's something that we need to take into consideration. So here we illustrate what the pathologists see in the progression of infection by this bacterium with chronic gastritis. Over many decades, in fact, chronic gastritis causes damage to the lining of the stomach, which is then replaced by these types of cells that resemble the intestinal cells, and this is what is called intestinal metaplasia. We can identify these cells by these nice colors. These are special stains. After intestinal metaplasia develops over the years, then dysplasia may develop. Now this looks very different and in fact may form a nodule, like a little polyp, in which case it would be an adenoma. Within these lesions, high-grade dysplasia may occur, and then there is a significant risk of progression to carcinoma. So then there's, at that point, we hope that a gastroenterologist would be able to remove that lesion endoscopically, and that would be an approach. Whereas generally, if there is a larger carcinoma, then we receive, but we know that the patient will be seen by Dr. Kaharchik or Dr. Dempsey. So there are some important considerations. We can continue to reduce risk of disease once we know the causing factor. So in the case of Helicobacter pylori, it's actually been shown that by eradicating the infection, one can actually reduce the incidence of this particular cancer in the population. So it's important. And gastroenterologists are on top of this. If a patient is diagnosed, there are antibiotic therapies that are very effective to eradicate the infection. But importantly also, and as we are doing more and more of these minimally invasive small endoscopic resections and preserving the stomach, in the residual stomach, if there is a Helicobacter infection, it is important to eradicate that infection because it will reduce the risk of the appearance of new gastric cancers. So now for esophageal cancer. The numbers of esophageal cancers are relatively similar to the numbers of gastric cancer in the United States. Again, it's a disease that generally more frequent later in life. Men are also more affected, and that probably relates to a number of the risk factors that were already discussed. The progression of esophageal cancer comparing with gastric carcinomas is in fact very similar. So here we have a nice progression from the normal esophagus with the nice squamous lining of the tubular esophagus, and this would be normal squamous epithelium. Reflux esophagitis generally is at the as the underlying process before intestinal metaplasia develops. Again, we can in fact recognize these type of epithelium using different stains. This is hematoxylin and eosin, which is a routine stain, very inexpensive. So it's good for surveillance, and it's very, very efficient. After years of injury, Barrett's or intestinal metaplasia of Barrett's may progress to dysplasia. So one may see first the appearance of low-grade dysplasia, as shown here, and then progression to high-grade dysplasia. And again, this is a point where it's very important that if a patient is on surveillance, resection of these localized nodules can be very effective at eradicating this disease. But in some cases, patients already present with this advanced disease, and then other more intensive therapies will need to be performed. Now, I would like also to mention that throughout this pathway, there have been and there continue to be numerous studies to try to understand the process of progression. What are the molecules involved? What are the pathways in the cells that we can target to prevent their growth when they become malignant? There's been a lot of research, and currently there are a lot of clinical trials, in fact, going on, but we are still waiting, for the big thing. A significant advance, however, was recently made with the discovery that both in esophageal as well as in gastric cancers, a proportion of those tumors express high levels of a protein HER2, which is also expressed in breast cancer. And in particular, in those types of tumors, patients may respond to treatments that are targeted against this protein. So trastuzumab or Herceptin are the drugs used here. So in the laboratory, in pathology, what we do is, beyond doing the diagnosis, we perform special studies to characterize the expression. So here we have immunohistochemistry in an esophageal adenocarcinoma that shows a 3+ result. That's a positive result. In some cases where the results are not clear from immunohistochemistry, we also perform another technique called fluorescence in situ hybridization, and this allows us to see the actual locus in the chromosomes, and we can see the normal chromosome copy is in green, and then we have many red dots. These are the locus for the HER2, and in this case there is clear amplification. So these tumors are also going to respond to HER2 treatments. Now, this is relatively about up to 25% overall of these cancers will have this type of abnormality and will make these tumors potential targets for treatment. And we're really hoping that more will be coming on the pike very soon so we can help more patients. And I conclude here. Thanks.
Thank you. Does anybody have any questions? Or yes? Yeah, well, actually, I'll address that because that's my responsibility. The pathologists don't meet you. And so for those of you who have gone through my office, you know, you wait 3 hours for me. I spend 3 minutes with you. And then there's a line of people. And one of the people that come in to meet you is my clinical research coordinator. And one of the things she asks you for, and you guys may remember signing them, or you signed so many things you probably forgot, is a consent form that will allow us to use whatever tissue's left over. It's de-identified. We don't know who you are or what it is, but your tissue then is utilized. And it's people like Antonia, researchers in pathology that utilize it. Some of my esophageal cancer resected specimens have gone across the street to the Wistar Institute. There's a guy there named Maynard Hurling, and he's trying to isolate out progenitor cells, the basis of where the cancer starts. And so a lot of things happen with your specimen, but that's as the clinician, that's my responsibility because I interface with you, and we need your permission to do anything.
Great point. Yes. Right, so let me elaborate a little bit on that. Very good question. In very recent years, with more of these targets becoming available, we actually had to create a whole new service, we call it molecular pathology within the pathology laboratory to allow for testing of tissues, either the current tissues or past tissues. So yes, if you come to Penn, for example, and you are recognized to have a tumor, and it could be actually you may have had a biopsy elsewhere or a resection elsewhere. We will, when we are basically asked to test that tissue, we have a service in place that will contact your initial hospital, request the material for testing, and then we do the test in-house at Penn and report the results through our system. So we are really now equipped to deal with that approach, which is very critical. And it's also very important to have a system in place because it can take an awful lot of time to get in touch with the departments, figure out who has the tissue, what is the right type of block. But yes, that's actually very common these days.
Yeah, so your tissue, the one that's used to make the diagnosis, is embedded in paraffin wax, and that they retain.
Forever.
Forever. And it's very cool. They actually can dissect out, do microdissection, and can get genetic material like that. So she's minimizing how huge of a...
It's a huge, yes. Yes. So in contrast to the stomach and the colon, where there are very well established hereditary syndromes, in the esophagus, we actually do not have a well characterized hereditary syndrome.
There's one.
But except
plantar and palmar.
right, not that involves, it does not involve adenocarcinoma, it does not involve these common types of tumors. But there is actually intensive research going on to try to identify, if not the main driving gene, the combination of genes that may significantly increase the risk of factors. So we talk a lot about personalized medicine and personalized diagnostics and new technologies such as deep sequencing, next generation sequencing analysis of genes that allows for the characterization of the entire human genome. It's really becoming possible to do that in a matter of a few days. So you can have your DNA, go to the lab, and in a few days we know all the bases in your DNA. Studies, of course, need to be done to associate the patterns of DNA with the occurrence of disease so that we can identify the groups of genes that can be markers of risk for each of the cancers. Among the so-called familial cancers, so there are different types. There are those that have a well-defined pattern of inheritance, and those have been better characterized. So there is Lynch syndrome, there is familial polyposis, there is familial gastric cancer, but there is a much larger group of cancers that have an increased family risk, but it's difficult to predict who and what markers to use. So those are still in current investigation.
You know, there's multiple theories on cancer. How do we get it? Where does it come from? And currently, a lot of people think there's kind of two components. One is that you have some genetic predisposition. And at some point in time, we're going to be able to know what that is and associate a number with it. This is your risk. And the second thing you need is some environmental hit or impact or exposure, cigarette smoke, tobacco, alcohol, something. And so you need the combination of the two. And so really, we need to know a lot more about ourselves and a lot more about our environment. And although it sounds pretty easy, I think that people have been thinking about it for a long time, and we're probably 40 years into it now and don't have even cursory answers. But, you know, as things pick up and technology improves, you get more information more quickly. Okay, we're going to move on, and then we'll ask some more questions at the end. Dr. Teitelbaum, who's our medical oncologist, who many of you know, will talk to us a little bit about medical oncology. Okay.
I just want to say quickly that some of you know me, some of you don't. This is a very exciting area to treat. First of all, they're very complicated cancers anatomically, and that's why we work so closely in a multidisciplinary fashion. And the other thing I'd like to say before I get started is Daryl, you spoke about cancer survivorship and conquering cancer, but one of the things that's really exciting for me is that we have cancers that we are not able to cure, but patients live a long time and live very well now with more tolerable therapies, more effective therapies, molecularly targeted therapies. And so, you know, a lot of our hope in medical oncology is that we're turning the C for cancer into C for chronic. And there are, you know, we don't cure high blood pressure, we treat it. We don't cure diabetes, we treat it. And I have many patients that live months, years, and live well. And so there are many different ways to survive cancer. And I actually really hope that the cancer survivorship programs will embrace some of these patients that are living with cancer and living well. And in this population now, increasingly, are patients with esophagus and gastric cancers. And just very briefly, we've gone through the anatomy. And in truth, this is actually really relevant. Even though it's one organ system, or at least we used to think so, and there are different cancers encompassed in these, increasingly we are treating these cancers similarly. I actually have a husband-wife couple, which is unfortunate in and of itself, treating them both with curative intent. She has squamous cell of the esophagus. He has adenocell of the esophagus. They're both getting chemoradiation, same chemo, same radiation, both with curative intent, different cancers. So it's really, we really think of this more globally now, even though we rely on our GI and endoscopists and pathologists to help us differentiate. We've learned about esophageal cancer, and again, I'm going to speak to some of the treatment modalities, but there's going to be more and more overlap in my treatments, particularly the chemotherapies, for esophageal and gastric cancers. When we think of them, we do look, oops, I'm sorry, let me just go back. We do think of the tumor size, the nodal status, and the presence or absence of mets. But what this means practically for me is if this is a localized and potentially resectable cancer, if it's a potentially resectable cancer, which might require some therapy before or after to increase the chance for cure, if it's a locally advanced and unresectable cancer, and sometimes these cancers are unresectable because the patients have cardiac issues or have had other surgeries, and so they might otherwise be resectable, but because of patient factors, they aren't, because these surgeries are among the most difficult that are done. And then metastatic disease, where surgery is not a primary modality, but where we may employ other modalities to help take care of the whole patient. The other thing that you hear a lot about is the timing of oncology therapies. And I know many patients that had treatment, particularly for esophageal cancer in the past, had their surgery first and then had chemo or radiation afterwards. And increasingly, we're looking to moving these therapies before the surgery. And what John will tell you is that this is a big surgery. So if we're able to move the chemoradiation prior to the surgery, patients are often more fit, and we're able to get more treatment in. And the other thing, if Jim Metz were still here, my radiation oncology colleague, will say, is that if we do the radiation before, we're able to treat a much smaller field. Whereas if you do it after the surgery, you have to treat the entire field where that surgeon's scalpel was. And when the field is larger, then the treatment is more toxic. So we're really looking at ways to move these treatments before the surgeries, and I'm going to get into some of those advantages. There's also treatments that we do after the surgery, and then treatments in the metastatic setting, the setting where it's spread outside of the original location, that are not associated with surgery. And part of the reasons these cancers that we treat so aggressively when we find them in a localized setting is that we know that, you know, not only are they near a lot of vital structures, heart, lung, but there's a rich bed of lymph nodes and blood vessels around them. So we know they really have an opportunity to spread outside the original location, and that's why we treat them so aggressively up front. So again, speaking to localized treatment approaches, and you're going to hear more from Drs. Dempsey and Kaharchik, but we do look at surgery at the mainstay of curative therapy for esophageal cancer. There are those patients for whom surgery is not an option. There are cases where we do cure patients with chemoradiotherapy, more so for squamous cell than for adenocarcinoma, but these rates are much lower. And increasingly, again, we're looking at combination approaches. This is where you hear the term trimodality, meaning surgery, radiation, and oncology all working together. Again, speaking again to the preoperative setting, we have situations where we can give chemotherapy alone, radiation alone, and increasingly chemoradiotherapy. I told you I'm interested in GI cancers. I actually dream in these plots at night. And the key here for me is that it passes, you know, we call it the finger breadth test. So if you can put your thumb in between the lines. And when the lines split, those patients on top are living longer. And that's what motivates me every day. And so this was a study out of Europe, actually, that showed that patients that got chemotherapy before surgery lived longer. Used to have a bigger debate actually about preoperative chemoradiotherapy, and for every positive study there was a negative one. But we were always tantalized by the prospect as if we could give chemoradiation first, would patients do better? And the things we knew were that those patients, a certain percentage that wasn't zero, had complete pathological response after the surgery. And that meant when they took the esophagus out, they couldn't find any evidence of tumor in that specimen anymore. The 5-year disease-free survivals were higher, but it came with a big price, a lot of toxicity. Traditionally, we gave 5-FU, cisplatin, and radiation therapy. Many of these patients required a feeding tube. You required a port, which is a venous access device, which many of you are probably familiar with. And there were some patients for whom it was just too toxic to even consider before surgery. And I'm happy to say, actually, when I was updating this, I was really intrigued to look over our practice styles and how they've changed over the past year, because the cross study has really changed things. We used to give infusional 5-FU and a weekly platinum dosing with the radiation. It was toxic. You needed a port. 50% of the patients needed a feeding tube. Many patients got hospitalized somewhere in the course of their therapy. Many patients required fluids, particularly towards the end. And it wasn't easy to give. And the other key thing in this whole thing, we have to have nutrition meet with people weekly to make sure they're nutritionally replete enough during this chemoradiation process, because the surgery really requires intact nutrition stores to be able to heal. So we were working really hard to keep these patients well. Cross study is the biggest study looking at resectable esophageal and gastroesophageal junction cancers, multi-center, randomized, phase 3, and they looked at almost 400 patients, and they randomized them to either chemoradiation with weekly low-dose carbotaxol plus radiotherapy, and this is actually a lower dose than we give, versus surgery alone. And then they went to surgery versus surgery alone. This was the largest study to date. It did suggest that the chemoradiation arm was better. The patients lived longer. And what we're really struck by is that it's really well tolerated compared to what we were doing before. In these patients, 92% of them had a margin-free resections, better surgeries. 32% of those patients, again, had this pathologic complete response where they didn't find tumor in that specimen. The postoperative complications were similar, and it was really tolerable. I actually have a patient that recently called me up. He's in his 5th week of chemoradiotherapy. He goes, said, Dr. Teitelbaum, I'm missing out on something. And I said, what? He goes, my friends say I should have a port. And I said, well, you don't need one because you don't have to. And he accepted, well, once I explained, he accepted it. I have another patient, 89-year-old gentleman, who's actually getting proton radiotherapy to a localized esophageal cancer. I'm begging him to take the chemotherapy. I'm almost reluctant to hand him patient information sheets on chemotherapy because it lists a lot of side effects that I actually think he's not going to get. So it's really increasing the population of patients that I can treat, older patients, patients with more medical problems. They're not even losing their hair. And I think I'm getting them fitter to surgery. We do know that there's those patients for whom surgery is not feasible, and there are some patients that live long and well with chemoradiotherapy alone. And this graph actually just says it's better than radiation alone. Radiation alone is almost never curative. In the metastatic setting, we actually have a lot of other options as well, and I'm going to turn my attention to chemotherapy, but we have localized options for promoting people's nutrition, which makes them live longer and better. And radiation is actually among these, in addition to the GI techniques. We have patients that are not curable, but we'll do combined chemoradiotherapy to keep their swallowing tube open, to keep their esophagus open, so that they have more natural swallowing. Looking to chemotherapies, there are lots of them, and there are lots of combinations, and trying to figure out what the right treatment plan for each setting is really important, and that's really the multidisciplinary approach that Jim Metz was talking about. Just turning briefly to gastric cancer, we've heard about the differing incidents around the world, and that is part of the reason that there are scoping programs in place because of these higher reported incidences in the population. But it is a global problem and one that we are very familiar with. The one thing that I will say is, gastric cancer doesn't have the best reputation when it's not in the curable setting, but we do know that chemotherapy is better than nothing. And people are afraid of chemotherapy. I always say, this treatment goes everywhere blood goes. It's really tolerable. And what we found, actually, they've gotten better in the studies that we do, and they've put quality of life parameters in, and they found that patients actually feel better. when they get the chemotherapy. So something I'll often say is, you know, the side effects of the cancer are worse than the chemotherapy. And we have a lot of supportive medications now that boost your white blood cells, red blood cells, you name it, I can boost it. And our anti-nausea medicines, even better in some ways than the chemotherapies we developed, our anti-nausea medicines are incredible. So virtually every patient, I can say, I can control your nausea, I can really treat you. So chemotherapies. The regimens that we typically use are doublets and triplets. And again, proposing, and this actually goes for esophageal cancer as well, proposing a doublet or triplet chemotherapy to someone that has advanced esophageal gastric cancer is not an easy proposition. I'm going to dodge this one actually. We've looked at the neoadjuvant preoperative therapy in gastric cancer. This one's still open and looking at chemotherapy before the surgery. What we tend to do more now is after patients had a surgery with curative intent in gastric cancer and stomach cancers to treat them afterwards. And this is actually one of the most important studies in oncology. It was a real proof of principle that chemo and radiation can decrease both the systemic risk and the localized risk of the cancer coming back. And again, you see my curve splitting, supporting the interventional arm. And these patients had a stomach surgery, and then they had a month of chemotherapy, with the thought being that you could mop up any loose cells that had escaped, trying to cope with the systemic risk of it coming back. Then it focused in on the localized risk in the stomach bed with radiation, and in this setting we give chemotherapy as sort of, we call it a radiation booster. It's sort of like the marinade for your steak before you put it on the grill. It just makes it work better, and then some chemotherapy afterwards. And when we're thinking about really refining our techniques, more is not always better. And this was a big study. You can always tell from our studies when they were designed. This was 2001. It went on for almost 10 years before we had data. And we used what was a metastatic regimen in the postoperative setting in these patients compared to 5-FU alone. And what they found out and reported last year is that the 5-FU was just as good. And giving these patients more was more toxic, but didn't improve their survival rates, leading to the adage that more isn't always better. There was a big study actually just at the end of January looking at adjuvant postoperative capecitabine, which is an oral 5-FU, and oxaliplatin, which is an updated platinum in gastric cancer after very extensive resections. And these patients, they actually omitted the radiotherapy. So this is another way we're looking, you know, we have everything we can give you, but let's see what we can get away with and still have equal opportunity to cure you in a more tolerable fashion. And this was a phase 3 big study looking at patients that had D2 gastrectomies, so more aggressive lymph node resections versus chemotherapy alone. This was an Asian population, so we'll have to see how we can extrapolate it to ours, but we did see improved disease-free survival. It does come with more toxicity. So those patients with unresectable gastric cancer, looking at combination therapies, again, chemotherapy is better than no chemotherapy. And some new drugs have emerged. Some of you may be familiar with these. Irinotecan, which is a topoisomerase 1 inhibitor, taxanes, oxaliplatin, which is a third-generation platinum more targeted to the gut, Xeloda, which is capecitabine, which is an oral 5-FU, and Herceptin, which is what Antonio was alluding to, as we target the therapies. And this is a biologic adjunct, which I'm going to get to a little bit. Taxotere caused a big stir a couple years ago when they added it into chemotherapies. It was higher response rates. It's not easy to give, and a lot of us are not giving it in the frontline setting, although we keep it in our back pocket. But there was an important study a couple years ago called the REAL-2 study, and what they did, the traditional model had been of cisplatin and 5-FU, and they substituted capecitabine, which is an oral 5-FU, and oxaliplatin. And actually the goal of the study was to show that they were not worse, that they were not inferior. And what we noticed, though, was that patients had less anemia, less nausea, vomiting, almost no hair loss, less fatigue, and less kidney toxicity, which meant they all felt better, although it did come with a price of peripheral neuropathy. And again, the curve split wasn't designed to test for this, but those patients actually did better. And you have to think that when patients are feeling better, they're going to live longer, and that's sort of how I approach it. S1 is a drug not available here, but it's under investigation. It's another 5-FU analog. And when we're looking at biological treatments, that's where we're really, I think, pushing the margins. Avastin, a lot of people think about, we've tried to extrapolate it from the colon cancer setting. It's been a little bit disappointing. Erbitux is a drug that actually I think we really need to keep our eye out for. I have Martha Stewart's picture because it's the drug she bet on that put her in jail. And it's kind of ironic that it's associated with something beautiful because actually many people get a rash that can be cumbersome to deal with. But it comes with very little additional toxicity. And the beauty of these biologic agents is they generally don't have bone marrow toxicity or nausea as components of their side effect profiles. So we can add them to standard chemotherapies and they're tolerable. This is a study that actually we're still waiting for the mature data on. It used 3 different backbones, and all 3 arms in these were esophagogastric cancers had cetuximab in them. And actually, my other favorite thing to do is to fight insurance companies. And I was so intrigued by how well patients did on this combination that even though it's not FDA approved yet in this setting, although we use it in the colon cancer setting, I fight to add this to every patient with metastatic disease. And much of the time I'm able to get it through. And what I've found in terms of patients living longer and better is really impressive with a minimum addition of toxicity. We're still waiting for this data, but the other thing that this showed us is that FOLFOX, which is a more tolerable regimen, was equivalent to the triplet ECF. We figured out what didn't work as well. And the key here, epirubicin is actually a cheaper medicine that was often given in Europe and more associated with distal gastric cancers, but we really had to watch people's hearts. People in the breast community know that we really had to track the anthracyclines. So omitting it is a really nice option for these patients. Looking at EGFR therapy, speaking again to cetuximab, we know that it's safe in combination. It doesn't work well alone. We think it works better, increasing the response rates, and we're really still waiting this final data. But again, when I'm really trying to fight for a patient, I try and get this. Avastin was disappointing. Avastin is bevacizumab. It's a VEGF inhibitor. It targets the blood vessels. Tumors are parasites, and they grow blood vessels to feed themselves. So this tries to block the tumor's ability to grow blood vessels to feed itself. It was kind of scary to give it in esophagogastric cancers because these cancers can bleed. So giving somebody a drug that can make you bleed to try and treat the cancer was a little cumbersome, but it actually didn't bear out, and it had no improvement in overall survival. Interestingly, though, no significant toxicities either. The study that Antonio was talking about is the TOGA study. Finally, we get an oncology trial with a good name. And yeah, ours are really boring. The cardiologists have great names. But 22% of patients in that sample were HER2 positive. And as soon as I actually got wind of this, I think I had the first patient that we tested at Penn. I haven't had a positive one yet. I keep trying. And recently, it was very highlighted to me the importance of testing pathology from outside labs. The young woman come in with a positive HER2, and her outside oncologist had started her on Herceptin, which is actually well tolerated but can have some cardiac risks. And resent it, and one of Dr. Sepulveda's fellows called me and said they'd done the test wrong, and she's actually HER2 negative. So it actually added a testament to the fact that we retest our pathology and make sure it's done properly. I don't think it harmed her, but it's always better not to give something that's not going to help you. But this TROGA trial design was really one of the big steps forward in gastric cancer. 800 patients positive, and in those patients, they randomized them to either have the trastuzumab, the Herceptin, or not. And they lived longer. Again, we saw a statistically significant improvement in survival in these patients. So we decided it was better than chemotherapy alone in those patients. So this is a biologic adjunct. This is a monoclonal antibody. It's different from our cytotoxic chemotherapies without a significant increase in toxicity. And again, we had to check the cardiac status on these patients. So we have a lot of things under investigation. I think these molecular targeted therapies are really the future, and figuring out if we can give things orally or if we can make the treatments we have more tolerable. Because as these patients are living longer, it really behooves us to make them live better. The other thing I actually want to mention very briefly is something that we now have available at Penn, which is HIPEC, and it's for those patients sometimes in gastric cancer and other bowel cancers that get cancer and lining a very difficult condition to treat, peritoneal carcinomatosis around the bowels. And there's a specialized surgeon now at Penn who I actually work with very closely, and in those appropriate patients, they can actually debulk those tumors like they do in ovarian cancers, when you hear people get debulking, and actually put heated chemotherapy around the bowels to help treat it. And this is newly available at Penn and a resource that I'm very interested in. sterile. So that's, we actually try it on all of them. Oncologists, if we get something good and we look for the marker, GI stromal tumors are very unique because they have that c-KIT signature. And we're looking for the predictive signatures like HER2 new status on these patients. EGFR, it'll be interesting. That's where the future lies. So, that's truly the personalized medicine and things like tissue banking, which is what you were, actually the institution is doing a huge investment in tissue banking so that even if we don't have the answers today, we'll still have your tissue in reserve later. Because what we do find is in the original tumor, that signature stays the same. So if you have a metastasis to your liver, if it was HER2 positive at the stomach, it'll be HER2 positive at the liver. And we're hoping that'll help us predict the future treatments for other patients as well. And we are searching for those environmental factors. I mean, we've tried. I like the spices. I don't know. So I can't speak to the diet itself. We do know that patients that have lower risk, or people that have lower risks in their native countries sometimes move to our country and their risk is equivalent to ours. So there must be environmental factors, be they diet or pathogens, toxins in our environment. I don't know that it's been completely identified. I think that, some of the pickled foods and salty foods in Asia are associated with a higher risk of gastric cancer, and some of the smoked foods, yes, the nitrosamines. Yeah, so I think there probably are dietary and local factors. Believe me, we're interested in them because we're always trying to figure out how to modify our own environment. But I don't know that they've been completely...
Yeah, one of the best studied groups are the Inuits. It's an Alaskan Inuit community. They have a very high incidence of esophageal and gastric cancers, and it's been traced back to nitrosamines, which are a compound that are found in smoked fish. And their diet is almost, especially during the long winter months, is almost entirely smoked fish and seal and everything.
And that's why you'll hear people say, don't barbecue too much, although,
Come on.
Who knows?
I have a smoker. I like smoking.
I think we treat it once we find it, but improved sanitation may, but no. Child, I'm going to turn it over to Gastric.
So yes, acquisition of the H. pylori infection, generally during school years. So very early in life, in fact, and it goes on often asymptomatic. Yes, exactly. Absolutely. Through direct contact. So large families, underdeveloped regions tend to have more of the disease.
And you tend to make antibodies to it. So there is a serology test that's not 100% accurate, but if it is positive and you've never been treated, it probably indicates that you have the bug.
Yes, the only issue, one of the issues I think, and Vinay can also comment, because they do more of these tests than actually we do, but the serology test does not really tell you whether you have an active infection, because you may have IgG, and it's the type of antibody that we are detecting with the current tests. So, but there are other tests like the urea breath test, which is a very simple test that's not invasive, does not require an endoscopy, and tells you whether you have active infection or not. There are a number of other tests, but I would say probably this is the most commonly used, right? Oh, yes, there's work.
There is work. The other thing I was going to say is that there's also a stool antigen that you can check in the stool for H. pylori that is also accurate. How long? The breath test. Well, you can recheck in 6 weeks. We like people to be off the PPI for at least 4 weeks, if preferable, because that does interfere with the positivity of the H. pylori. And then getting back to one thing about diet in India, turmeric, curcumin, is being studied actually extensively for colon cancer, and I'm not aware of any linkage, but that's one potential thing that they found in the diet. Yeah, as anti-cancer. Yeah. So.
Yeah, there's a whole field of academicians called ethnobotanists, and they basically travel around the world, sometimes to very indigenous communities, and try to look like like, for example, eating tree bark and people get better. Well, that actually then later on they take it back to the laboratory, study it, extract the active component, and that's manufactured into a drug. So it's really kind of neat if you have time and enthusiasm and people to think about it, because it may be that a lot of the answers are there. And the other thing, talking about H. pylori, is fascinating because there are a number of cancers that are associated with infections. There's cancers that can come from a virus called Epstein-Barr virus. There are head and neck cancers and cervical cancers that come from human papillomavirus. And you hit the nail right on the head. For example, HPV. There's now some vaccinations available. And so that's another route. And that goes back to our question is, how do cancers develop? You have a disposition and you also have an environmental component. And the trick is to figure out what each of those are. That is correct. Yeah, that's correct. So you have some predisposition to it. So your genetic makeup allows you or presents you with some a priori risk, and then you have the environmental insult, and the two of them together combine to give you the disease that you end up with. Okay, and then we're going to get to Dr. Dempsey.
Yeah, the first one is there any general way of surveillance for further chemotherapy that we take PT, because for the patient radiation treatment and this radiation has the potential of creating cancer. And the second question is, have you had any patient who has successful esophageal cellular lymphadenectomy, and he's now on Deloda for a year and a half, and he's not Deloda.
So yes, but normally we wouldn't treat them for that long. Usually the postoperative therapy is about 6 months, and then we put them in surveillance. And you bring up a very good point. Radiation is our friend, but it can also be our foe. And there's been increasing interest in long-term effects of our radiographic surveillance. And I have to say, they say the risk is a little increased at 20 to 30 years, but in my mind, someone that's made cancer before may be at an increased risk for whatever reason to make it again. So whenever I can, I actually have converted a lot of my patients to abdominal MRIs. I wish I could do MRIs in the chest. I try to limit the chest imaging as much as I can to try and limit that exposure down the line. That is something that's actually kind of been in our forefront of our attention more recently in the past 1-2 years, when we're actually tracking how much radiation we get and all of these different exposures.
Yeah, I mean there are radiation-induced cancers. I mean you can calculate out all the dosages, and they tend to be fairly rare and unusual. And I think when you're in your 50s and have one cancer, you're at much higher risk to develop a recurrent cancer than you are a radiation-induced cancer. So I'm a big proponent of long-term surveillance. The only thing I'd say is I'm not sure that PET-CT is the best. It actually oftentimes opens up many more questions that turn out to be false pathways, and those oftentimes engender a lot of anxiety, both in you as the patient and in me as the ordering physician. So we kind of, try to do our best to catch a recurrence or another primary cancer if it occurs early enough that we can intervene. We're going to finish up with Dr. Dempsey. He's going to talk to us a little bit about surgery of the esophagus and stomach, and then I'll just have a couple concluding remarks, and then we're going to go have lunch.
I love this picture here. If you're a teacher, you immediately recognize this kid hasn't done his homework here. And this kid probably hasn't. He's faking it. He's got it. And, of course, all the girls have done theirs. So that's, focus on GI cancer. Well, it's a privilege to be here today, and it's indeed a privilege for me to work with such great colleagues as Penn, where, in my opinion, the GI cancer team is second to none in the world, really, and GI cancer really requires a multidisciplinary approach. There's no question about that. There's also no question about the fact that in this country today, most people who have been cured of esophageal or stomach cancer have had a surgical resection. We all look forward to the time when maybe that's not necessary, where endoscopic and radiation and chemotherapy will cure more and more patients without a major resection, because, as Dr. Kaharchik says, nothing works like your own esophagus and stomach. There's no question about that. You've seen these anatomy pictures before, so I won't belabor this. This is the operation that Dr. Kaharchik and myself, or Dr. Williams, my colleague, would commonly do for esophageal cancer, where you make a tube out of the stomach. You can actually make a nice long tube out of the stomach with the blood vessels based distally, and bring it all the way up into the neck or high into the right chest as a conduit to replace the esophagus. And I'll let Dr. Kaharchik make some comments about esophageal surgery. Now, one question you might ask is that if you have a tumor that's limited to a certain spot on the stomach, why can't you just take out a little bit of the stomach or a little bit of the esophagus? Why do you have to have the whole esophagus out or most of the stomach out? There are technical reasons for that. The analogy might be you've got a leak in a pipe, but it's easier to replace the whole piece of pipe from one joint to the next joint. That's one reason, but the other reasons are blood vessels and lymph nodes, and you need to drain the tumor, and you need to remove them with the tumor, and also some of these tumors travel underneath the lining of the stomach and the esophagus, and you want to make sure that you get enough tissue beyond the palpable tumor, that the pathologist, Dr. Sepulveda, doesn't call you up 4 days later and say, your margin shows microscopic tumor cells at the margin. Now, I want to talk about stomach cancer. Most tumors of the stomach, as shown here, are adenocarcinoma. There are lymphomas of the stomach. Most of them nowadays are treated non-surgically. There are GIST tumors and sarcomas of the stomach. Most of the GIST tumors that we excise in our hospital are probably not malignant, although many of them have malignant potential, but some, as we heard earlier, can spread to other organs. Now, we mentioned this before. Stomach cancer in our society is actually less common than it is in some other countries, and we like to think about risk factors. If someone has a heritage or they're first generation of immigrants from these countries, their risk of stomach cancer might be significantly higher than if their family's been based in this country for many generations. And it's interesting, as your family moves from a high risk to a low risk country, the risk of the cancer goes down with successive generations. And the other side of the coin, if you move from a low risk country to a high risk country, you acquire that. So there's probably, as alluded to, important environmental factors. And men uniformly get stomach cancer more commonly than women do. It's a disease that increases in incidence as we get older. It's uncommon, although we heard a very moving testimonial earlier from a gentleman who developed esophageal cancer in his 30s. It's unusual to get stomach or esophageal cancer at a very young age, but it increases quite a lot as we get older. Now, it's unusual to have a totally normal stomach this year and then get an endoscopy next year and have stomach cancer. Unless you have hereditary gastric carcinoma in your family, and you'll know that. You'll have first-degree relatives who have adenocarcinoma of the stomach. And if you have that, you should consider getting genetic testing and maybe even a prophylactic gastrectomy. But most people, the large number of patients that have gastric cancer, go through a phase of inflammation. Normal stomach mucosa, normal inner lining, that is, and then they get inflammation, very often related to Helicobacter, sometimes related to autoimmune factors, and then the inflammation gets metaplasia. In the esophagus, Barrett's esophagus is metaplasia. In the stomach, the same thing happens. And then in some patients, the metaplasia progresses to dysplasia. And then the dysplasia progresses to cancer. So there's a sequence. So if someone has atrophic gastritis or chronic gastritis, their risk of developing cancer is going to be higher. And there are increasingly genetic abnormalities defined along the way. There are other risk factors, but by the time we get to where we are all here in life today, there's not much really we can do to. I'm not going to stop eating cold cuts because they've got high salt. I don't think doing that's going to significantly affect my risk of stomach cancer. Now, this is an important cartoon, and this is related to why, as clinicians, we put our patients through a whole lot of staging tests before we submit them to a gastrectomy or an esophagectomy, because these are large operations that have a risk to the patient. These operations have a risk to the patient of the order of magnitude of having open heart surgery or having a lung removed. Not a small operation like having your gallbladder out or having a knee arthroscopy, okay? So I tell my patients, if I'm going to take out most of their stomach, I tell them if I do that operation on 100 people just like me, 2 of them will not leave the hospital, okay? So 2 patients out of 100 will die in the hospital with complications. And if it's an esophagectomy, if Dr. Gaharchek is going to do an esophagectomy on me, we would probably tell the patient that he or she had a 3 to 4% chance of a life-threatening complication. So it's a significant operation, and as many of you know, you never eat the way you did before you had that operation. So what does that mean? Well, that means as surgeons, we want to be as sure as we possibly can that we're going to cure the patient of the disease before we put them through the operation. So we do CAT scans and PET scans to make sure that there aren't any tumors outside of the scope of what we're going to include in our resection margin. And we do endoscopic ultrasounds to see if there are large lymph nodes around or real thick tumors, because we know that if the lymph nodes are involved or the tumors are really thick, those patients are at higher risk to relapse even if you do resect the primary tumor. So they'll see Dr. Teitelbaum and Dr. Metz. Maybe the patient's lucky and they've got a real thin tumor, a T1 tumor, that then I can do endoscopic mucosal resection on, and that's all they need because it's so thin that the tumor cells never get into the lymphatics to get to the lymph nodes. So staging of these tumors, clinical staging before we do the resection, is very important. And many of us, even when we have them staged as local regional disease, that is CAT scan, PET scan, endoscopic ultrasound, showing no liver metastases, showing no big lymph nodes, even then, very often after the patient goes off to sleep to have the operation, we'll slip a little laparoscope in to look around, just to make sure, because 5 to 10% of the time, all of those studies might miss something. And then if the patient does have a little liver metastases, we biopsy it, and we might not do the resection at that time. We may send them back to Dr. Teitelbaum and Dr. Metz for neoadjuvant treatment to clean up that disease, and then we go in and resect them with a higher likelihood that we would be able to effect a cure. So you know stage 1 is better than stage 2, is better than stage 3, is better than stage 4, and on all of this you can find on the internet if you want, but the T1 is how thick the tumor is, the N1, N0, N1, N2 is how many nodes are involved and where the nodes are. If there's a lot of nodes involved, quite a ways away from the tumor, it's an N2. And of course, if M1 means that the tumor has set up shop in distant organs like the liver or the lung, that sort of thing. This, if someone had a malignant tumor of the lower stomach, this is a cartoon of the operation that they would have. This is a subtotal gastrectomy with a Billroth 2 reconstruction. And this area down here is called the pylorus. This pyloric sphincter area is where the stomach regulates how fast the food gets out of the stomach into the small intestine. So, and we have to resect that to do this operation, and that predisposes some people to dumping syndrome because there's nothing that regulates how fast the stuff goes out here, and some people, if the concentrated food and liquid gets out too fast, it causes a phenomenon called the dumping syndrome. Now, if the tumor happens to be higher up in the stomach, closer to the GE junction, the best operation to do is a total gastrectomy. That's a bigger operation, and it's a bigger insult to the digestive function, if you will. However, the digestive function with this operation is better than if you cut out the upper half of the stomach and brought the lower third or so up here, because that creates intolerable bile reflux esophagitis. So this is the arrangement with a total gastrectomy. This is called a roux limb. And most of us would try to do a little pouch, make a pouch here to increase the capacity of the digestive system. Now, adenocarcinoma is treated with a formal gastrectomy because you want to get all the lymph nodes around and the blood vessels, and also you want to make sure you get good negative margins around it. But there are some tumors, and the GIST tumor, I guess, is the best example, that don't metastasize to lymph nodes and that don't travel under in the wall of the stomach. So you can wedge these tumors out, and very often you can do this with laparoscopic tools, which we're using more and more to do all sorts of gastric surgery and to keep the incision smaller and to speed the recovery. So I'll stop my comments there. Thank you.
Any questions for Dr. Dempsey? Yes. Yes. So, Dr. Dempsey, you want to answer? So, one of the things that I like to tell people is, part of our goal is to do an operation that has the highest chance of curing you and has the least effect on your overall well-being. But you should never pick the technique or the technology. Your goal is to be cured. And so there are some instances where a more invasive operation is the right one because it has a better chance of curing you. For example, institutionally, we've chosen not to do minimally invasive esophageal surgery on patients that get preoperative chemo and radiation therapy because those patients have a lot of lymph node disease. So there's all kinds of considerations that go into those decisions. And really, you should talk to us about that. And I like when patients come in with a whole host of things printed off the internet and stuff. It doesn't bother me at all.
John and I do a lot of minimally invasive surgery. A fundamental principle of minimally invasive surgery is you must do the same operation minimally invasively that you would do if you had a larger incision. If you don't do that, you're shortchanging the patient. The other thing it's important to understand is that the risk of the surgery with minimally invasive gastrectomy or esophagectomy is no different. It's not less than the risk of the surgery with a larger incision. The recovery may be a little faster early on, but with the techniques we use now to help with postoperative pain relief, most of our patients have epidural catheters for pain relief for 3 or 4 days after the operation. Really, it's when you ask the patients a month or 2 later about their experience recovering, it's indistinguishable, one versus the other. So yeah, there are instances where the patient should have minimally invasive resection, but you have to do the right thing for the patient.
Mm-hmm. Yep. Yeah, absolutely. So for an early stage colon cancer, that's a great operation. Yes.
Yeah, the D1 versus D2 lymphadenectomy. There's a lot of controversy about whether doing a more extensive lymph node resection improves survival. Interestingly, the randomized prospective studies that have been done suggest that no, it doesn't, provided that you have enough lymph nodes removed with the resection. I think most of us feel that the more lymph nodes you can remove, the better. But I think the morbidity of a more extensive lymphadenectomy, I think, often doesn't the risk benefit is not there.
All right, so you've all been to medical school in the morning, and now we're going to have a test. We have to go to lunch. I just want to comment just briefly on a couple things. I just want to update you on esophageal cancer. We're on target this year to probably do about 80 or so esophagectomies. We have a very kind of cohesive, multidisciplinary group, which I think is vitally important. Not only interdisciplinary, but actually within the surgical group, a GI surgeon and a thoracic surgeon working together. I think that we provide you a better operation, less anesthetic time, and hopefully a smoother postoperative recovery. Institutionally, Dr. Chidang, I don't know if any of you, I don't think he visited our group, but you'll see him. He's the new director of the Abramson Cancer Center. We're doing a lot of internal reorganization, and I think it's going to benefit patients. We are setting up translational centers of excellence, and what that would mean to you as a esophageal or gastric cancer patient, it would mean that you would be going to a place where your disease, and your family would have access to people all the way from basic scientists to translational scientists who are, testing new vaccines or testing new things in the clinic, to clinical people who actually take care of you, and your information also will get transferred out to the outcomes people who look at, comparative effectiveness. Is the treatment you're getting effective? Is it cost effective? Is it effective in curing your disease? Is it effective in restoring your quality of life? And then the final thing I'll say, I'm glad Darryl walked back in because he said that his pain in his side make him feel alive. And I've been sitting here thinking about that. And you guys in the back, you're the thorn in my side. Okay, you make me feel alive. It's interesting because you all come here and thank us. But actually, I really enjoy what I do. I hope when you met me in the office or you met Dr. Dempsey, you realize, that surgeons are funny people. We sometimes keep our patients a little bit at arm's length, and that's because what you don't realize is we live and die with you. When you're in the hospital an extra day or you're coughing or you're leaking or there's a problem, we kind of take it personally. The nice thing is when we come back like this and you're all doing great, then we can finally be honest with you and tell you how we actually feel. So thanks a lot, and I hope everybody enjoys lunch.